Hello and welcome back to Curbside Ethics. I'm Dr. Stephen Bradley. I am an anesthesiologist and clinical medical ethicist. The purpose of this podcast is to provide information to empower clinicians to make better ethical and equitable decisions to benefit their patients. Last week, I didn't release an episode. I actually did an Instagram Live with Dr. Ben Simmons and Dr. Bernard Ashby. We talked about several topics that were submitted by listeners. We talked about some of the ethics of vaccine mandates, the use of vaccination status as triage for patients coming to the hospital. And we talked about vaccine passports and whether we should actually focus on immunization or whether that's by natural or vaccine-acquired immunity. If you want to check out that discussion, head over to my Instagram, Stephen Bradley MD, and it is on the IGTV section of my page. This week, I'm going to dig a little deeper in the question of should COVID vaccination status be used to make triage decisions. I've done quite a bit of reading on this subject. The Hastings Center actually released a really good comprehensive article on this very topic. It was authored by a Dr. Vu Tek Xuan, Dr. Abigail Lowe, Dr. Alva Ferdinand, Dr. Tan Liang, and Dr. Matthew Winia. So if you're interested, definitely check out this article. It's published on the Hastings Center's website. As you may have heard in the news, it's been in several articles how different clinicians or hospital systems have discussed using vaccination status during triage for patients seeking care. Once again, the hospital systems are being strained to capacity. Hospital beds are disappearing. It's a combination of physical space as well as the staff to support and provide care to these patients. In this setting, when there's not an abundance of options available, should patients' vaccination status be considered in making triage decisions? The short answer, in my opinion, is no, because there's a lot of variables at play in this situation and a lot of opportunities for bias and discrimination to rear their ugly heads and further contribute to healthcare disparities that we already know exist. The North Texas Mass Critical Care Guideline Task Force actually released some triage guidelines for regional hospitals, and these guidelines propose using a patient's COVID-19 vaccination status as a factor when deciding whether or not to assign an intensive care bed. I think there was a lot of uproar after these guidelines were released. They kind of walked back their decision. They clarified that this was not intended as a policy, but more so to spark a discussion between the task force and the physicians that are actively working at these different regional hospitals. And they further clarified their position that if they were to begin considering vaccination status and whether or not they should provide an ICU bed, that this would only be one of several other factors that might help predict patient survival from COVID-19 and not just as an exclusionary factor for whether this patient will be admitted or not. We're not strangers to triage. So in times of war or national disaster, Hurricane Katrina, triage is a set of conditions and principles that we use to provide appropriate care to the appropriate patients. The goal is to optimize the use of a limited resource. Typically, there's medical criteria that you use to determine whether patients will live or survive without an intervention and their likelihood to survive with the intervention. Patients that would take too many resources and have a low chance of survival are typically delegated to lower down on the realm of triage, and resources are prioritized for patients that are more likely to recover. A lot of the guidelines and ethical frameworks for triaging, especially when it comes to intensive care resources, use first order criteria for triage. First order, again, is that information that we know this patient is likely to survive or not likely to survive this patient is going to need a lot of resources or maybe not so much resources. After you get through the first order considerations when it comes to triage, there's a second order criteria, and this helps determine priority when there's a tie with the first order criteria. Second order criteria can involve different aspects such as justice or health equity. You can argue for days. There's a lot of contention oftentimes surrounding these second order criteria. Sometimes these criteria include concepts such as the fair innings principle, which would prioritize those with the least opportunity to live through the stages of life. And this would target an intergenerational equity. There's the principle of reciprocity, where those patients who have taken additional risk or burdens while making contributions to the society at whole should be prioritized. And then there's those folks that are capable of providing care to others. This was actually used in the beginning when we first rolled out the COVID-19 vaccines, and healthcare workers were some of the first people prioritized to receive these vaccines because we knew, or the concept was that treating them initially, or us initially, would allow us to go on to treat other patients. We have to emphasize that when it comes to triage, we have to remain grounded on the likelihood of survival. With this memo from the Texas hospital system that suggests the use of vaccination status as part of a multi-component assessment of patients' likelihood of survival, this somewhat brings it into context. However, there's still a lot to unpack with this concept. We have strong evidence that the COVID-19 vaccinations decrease the likelihood of developing severe COVID-19 and or death. We don't have a whole lot of information, though, on survival outcomes when comparing vaccinated versus unvaccinated critically ill patients with COVID-19. We just don't have the data to be able to fully risk stratify these patients. We also know there's multiple vaccines out there. Patients are in different stages of vaccination and different timeframes from when they were last vaccinated. And then there's patients that may have acquired natural immunity, and we don't know how long that lasts, and we haven't fully studied that either. So this is a very nebulous situation, and this is at the very start of where we would begin to use vaccination status to triage patients. Vaccination status may have an impact on reducing the odds of death from SARS-CoV-2 or COVID-19. However, once patients do have acute respiratory distress syndrome, or on a ventilator, or are critically ill, we don't have that data on who's more likely to survive, to my knowledge. Since we don't have this evidence on this situation, it's difficult to begin to apply vaccination status when you start to assess patients' likelihood to survive from an intensive care unit admission. This again would speak to using vaccination status as a first order criteria when you begin to triage patients. So if we can't ethically state that this is appropriate to use as a first order criteria, can we use it as a second order criteria for patients that maybe need a tiebreaker? We have two critically ill patients, both in the ICU or both wanting or needing ICU beds. Should we use this in that second order criteria? Is that ethically permissible? Another issue with this setting, even if you were to use this as a second order criteria, when you begin to consider patients' vaccination status as a criteria for whether or not they should receive care, you have to make considerations for accommodation for patients that are unable to receive the vaccine, whether due to religious reasons, due to their health history. Maybe they're minors and their caretaker has refused to allow them to become vaccinated. So you have to start making caveats and putting in place situations for patients that were unable to be vaccinated, not of their own volition. As we begin to break down these different situations, we start to kind of develop this picture where lowering a patient's priority to receive care based on their vaccination status should really only apply to patients who are able to receive the vaccine but adamantly refuse to be vaccinated. This is when you can start to compare other patient populations with other medical risk. People love to talk about heart disease and lung disease, patients that smoke. And this is a kind of a matched cohort where we have patients with these diseases that adamantly refuse or, due to addiction or dependence are unable to stop smoking or eating poorly. So I know a lot of people kind of from the jump start to compare these different patient populations, but really you get to drill down a little bit more. When you're looking at patients that simply refuse vaccination, it's a very similar thought process to patients that have underlying medical conditions that they're unable to manage on their own, especially due to volition. They choose not to. And as we know, a lot of patients with obesity, with heart disease, aren't necessarily making a conscious decision to continue living a healthy lifestyle. We can talk about that for days, but they don't wake up every day and say, no, I want to continue having my heart disease and I want to eat poorly. There's a lot more psychosocial nuances to that situation. If we continue down this path, this approach would lead to increased systemic inequities that we already know exist. Some members of the U.S., we already face disadvantages in terms of healthcare access and lack trust in the government or in healthcare. A lot of populations that are minoritized, that are discriminated against, do not have faith in the healthcare system. So when we start to drill down into the reasons patients have received or refused vaccination, rather, what credit do they get if they simply refuse versus they refuse because they have been treated unjustly and unfairly in the healthcare system, or because they don't have access to the vaccination? So you see there's multiple levels that when you start opening this can of worms, you have to examine all these different situations and scenarios to ensure that you're not worsening health inequity and discrimination. We can also talk about assigning priority based on vaccination status, because there's more to preventing severe COVID-19 than just being vaccinated. What about patients that have not received the vaccine, however, they wear masks every day, they stay in their house, they're not exposed to the general public, and they still manage to become critically ill? Or what about the patient that has received a COVID-19 vaccine and then goes and raves down in Miami and just has, travels the world and engages in risky behavior, and they become infected with COVID-19? So how do you distinguish between the other things that you can do to mitigate the spread of COVID-19? How should we decide between these patients that have not complied with other health measures or who have engaged in this high-risk behavior? Sometimes the principle of reciprocity is used to justify prioritizing vaccinated patients. It's the concept that being vaccinated reflects an individual's personal responsibility to his or her community to reduce the spread of COVID-19, to be a responsible citizen, and to do their part to battle this pandemic or contribute to the greater good. Again, this is what we use as an argument to prioritize frontline healthcare workers and other essential personnel to receive the vaccine early. Reciprocity. You receive the vaccine, you're going to continue to be able to help other people. This would make the vaccination status appear almost as a tiebreaker and be seen as a reward for those who chose to help their fellow mankind. We can't speak about rewards, however, without speaking of punishment, and essentially that's what you would be doing to people that chose not to be vaccinated. So since you did not help your fellow man, you were being punished by being second tier and looked over during the triage process. You're essentially penalizing people for being vaccine hesitant or refusing to receive the vaccine. And again, in order to not punish certain groups, you need to create a system to distinguish between patients who did not have access to the vaccine, those patients who wanted to be vaccinated but couldn't for some legitimate reason, whatever that is. And then there's patients who had access but chose not to. And out of those different groups, the group that simply volitionally chose not to be vaccinated would be assigned a lower priority to receive health care. And this is only after you've gotten past that first tier where they're all equal respects to their life expectancy and their critical illness. As you see, the situation is complex at best. This deep dive into some of the ethical implications of this task force's memo just highlights how complex this situation is and how difficult it is to introduce this new criteria of vaccination status into the current triage frameworks while ensuring that we're making scientific and ethical decisions about patient care. It's very tempting, and I think a lot of this is coming from a frustration from healthcare workers, and it's very tempting to go down this road of blaming the individuals who choose not to be vaccinated despite having access to the vaccine. We're beginning to tiptoe a little bit on or into the realm of paternalism versus autonomy and coercion. Using the vaccination status of a patient as a first-order triage consideration is not clinically justified at present based upon the information that we have or rather that we don't have. We cannot assume that vaccinated patients have a survival advantage once they are critically ill and or require mechanical ventilation. Although we may consider reciprocity to justify vaccination status as a tiebreaker between patients with similar likelihood to survival, this approach raises issues about why vaccination is being treated differently than other behaviors that increase a patient's risk of severe illness. This leads us down the road of a punishment for certain individuals that would continue to divide our society when we actually need to get along and work together to decrease the spread of this virus. So what are your thoughts on triage in the setting of COVID-19 vaccination status? I, again, think it's just too complex of an issue to institute now. We don't have enough information. It sets up a situation where clinicians can say, okay, you're not vaccinated. That's easy. I will cross you off the list and refuse you care. Go home and manage as best you can. And the more leeway that we give different groups to make these unilateral decisions affecting the lives of patients, we're opening the door to discrimination. We're opening the door to worsen healthcare disparities and the disparate care that minorities and marginalized people groups are receiving. Thanks so much for listening to Curbside Ethics. Would love to hear your thoughts. If you have any questions about medical ethics or you want to talk through a different clinical situation, feel free to visit my website, StephenBradleyMD.com. I have a link there where you can send me a consult. We'll keep it between the two of us, but happy to chat and talk through things. Also, if you're not listening to the Black Doctors podcast, or if you know someone who's interested in the healthcare professions, definitely check that out. New episodes released every Monday. It's the Black Doctors podcast on Apple, Spotify, anywhere you listen to podcasts. I'm Dr. Stephen Bradley, your host. Thank you so much for pulling up to Curbside Ethics.